2024. So I'm very happy to, or we are very happy to welcome Dr. Rajan Patel from the University of Oxford. But I will let Samira, Professor Rahimi, who will be in charge of facilitating the webinar, to introduce properly our guest speaker. Thank you so much for accepting our invitation. Samira?
Yes, thank you, Sharo. So it's my pleasure to welcome you to this webinar series for the presentation of Dr. Raj Patel. He is graduated from medical school at University of Oxford in 2016 and currently is a family medicine trainee based in Oxfordshire, and joined the Department of Primary Healthcare Sciences at the University of Oxford as an academic clinical fellow in 2020. And his ongoing research involved evaluating the role of remote vital sign monitoring in hospital at home setting, and his MSc studies was focusing on clinical education at University of Edinburgh in 2021, which he will present this study as part of his presentation in today's webinar. So just a couple of information about today's webinar. It's going to be 30 to 40 minutes as usual, with 20 minutes of question and answer section at the end. And if you have any question, please feel free to write it down in the chat box, or get your question to the end of the webinar, and keep your speakers at mute. And with that being said, I'll leave the floor to Dr. Patel. Right? Floor is yours.
Thank you very much, and thank you so much for the really kind invitation to present today. Yeah, thank you very much for the introduction, and thanks, Dennis, for helping arrange all of this as well. So yeah, my name's Raj. I'm a family medicine, I'm a GP trainee, so family medicine resident, due to finish my training in October, and I was going to present today some of the education research that I've done previously. My role at the moment as an academic clinical fellow is a program in the UK where you can train clinically and academically at the same time. So you have a sort of split role. So half the week I'm in a GP practice just south of Oxford, and the other half of the week I'm in the Department of Primary Care Health Sciences, so the GP Family Medicine Research Centre at the University of Oxford. But the presentation today is more specifically on the education research that I did as part of my Masters in Clinical Education a couple of at the University of Edinburgh, finished 2 years ago now. But I just wanted to firstly point out that we've had a wonderful stay so far in Montreal, enjoying the weather, and so I'm here with my family for the week. I'm very kindly was able to present today, so we're enjoying ourselves. But I hope you guys enjoy the talk that we've prepared for you guys today. The first bit, so the talk today is about a type of assessment format called script concordance testing, or SCT. So what I thought I'd do first is introduce what the SCT question format is, just to contextualize it for everyone, and I'll go through what type of assessment it is and how it works, and why I decided to study it for my master's dissertation project. Then I'll give a sort of brief summary of this research. So it was looking at GP trainees, family medicine residents, learning experience of using this assessment format, the SCT, as a learning tool rather than as a sort of actual evaluation of their clinical skills, but more as a learning exercise. And then I did a sort of piece of research on the back of that. And then one of the things that came out of that work was looking at standard settings, so sort of setting the pass mark, and how that works for this particular assessment format, and what role that plays in still using it as a learning tool, how can we actually sort of do a sort of more feasible and practical way of standard setting this assessment so that it can be used in the sort of learning formative context. And then at the end, although, like I say, if anyone has questions or comments through the presentation, by all means, please put your hand up or put a message in the chat. But there's a bit of time at the end for any questions and further discussion. So part one, the SCT is the type of question, it's the type of assessment format that I looked at, stands for script concordance testing. And essentially the reason why I ended up looking at it is as family doctors, we have to make quick, accurate decisions, but we're often dealing with uncertainty, ambiguity, complexity, and that's sort of just the context in which we have to make clinical decisions. So how we kind of help trainees and myself as a trainee actually learn to develop these skills in terms of like a formal structured way remains relatively unexplored. There's a few pieces of work out there, but ultimately it often reflects mainly on sort of work-based placed experience and just sort of being in clinic, but actually sort of structured formal ways of developing that in sort of group settings remains not particularly well explored. So the script concordance testing is a question format that was originally designed to test clinical reasoning, and essentially what I've shown here is the sort of steps of clinical reasoning. I'll just run through this and then I'll show you how this sort of aligns with the SCT question format. So in theory, how we sort of go about reasoning through a problem is that we get presented with a problem in family medicine. As the doctor, we're kind of developing a few different hypotheses about what might be going on. We're using that to gather more data. So we might be asking certain questions, or we might be doing certain blood tests or basic investigations, and we collect more and more data to try and test the hypotheses that we've generated. And so we interpret that data, we reevaluate our original hypothesis of what the diagnosis might be, or what test might be helpful, or what medication might we start. And then we use this data that we've gathered, we interpret it, and we use it to sort of reevaluate our hypothesis. And then we use that with the patient to make a decision. And these steps are what the SCT question format was designed on. So what you get given is a case scenario. So it's a little clinical problem, a little sort of few lines explaining the situation. And then the question format tries to mirror these steps. So they present you with a hypothesis. So it's if you were thinking, and that hypothesis could be a diagnosis, say if you were thinking of this diagnosis, or thinking of arranging this test, or thinking of starting this treatment. So you get given that hypothesis. And then the question gives you a new piece of data. And that can be a clinical piece of data. And then what the candidate is asked to do is evaluate the original hypothesis based on this new piece of data. And so this becomes, the hypothesis becomes, and then the response is indicated on a 5-point scale, which goes from -2 to +2, which essentially becomes very much less likely, all the way to much, much more likely, or somewhere in between. So as the candidate, you're kind of using this new piece of information and trying to reevaluate the hypothesis to come out with, well, how has this piece of information affected what I'm thinking at the moment? So I'll just kind of show you an example of what that actually looks like. So this is the sort of short vignette. It's deliberately designed to have a little bit of ambiguity, a bit of uncertainty. Not all the information's there, but it's not supposed to be really sort of very, very ambiguous, but it's supposed to have a little bit of, okay, well, we need to gather a bit more information. So here we've got a 70-year-old man with palpitations. He's got a history of high blood pressure, type 2 diabetes, which is a new diagnosis and it's causing him some stress. And then these are his medications, so an anti-blood pressure medication, or 2 anti-blood pressure medications, and a medicine for his type 2 diabetes. So that's the little vignette. And then this is the question structure. So it's saying, if you were thinking of the following diagnosis, and the question gives you the diagnosis, and then this new piece of information becomes available. So in real life, you may have had to ask this question, but here in the question format, it's given to you. So the new piece of data that you've been given is, well, he drinks a significant amount of alcohol per day. And then what the candidate is now asked to do is say whether the original diagnosis, so the atrial fibrillation diagnosis, is going to be less likely, the same, or more likely, given the fact that we now know that he drinks 6 to 8 units of alcohol per day. So that's what the candidate's asked to do, to kind of give an answer on this scale about how likely is this hypothesis given this new piece of data. And then each question comes in 3 parts, so I won't talk through these ones, but you see it comes as one vignette, 3 questions, and the candidate will then mark 3 points on the right-hand side of this scale. And so then the question, well, if you've got a scale, how do you actually mark the assessment? And basically what happens is on this scale, what you do is you collect responses from a panel of experts beforehand. Typically from the literature in terms of this assessment format, the SET, fully qualified specialities, so people who've been working as family medicine doctors for a period of time, or a consultant or an attending in their speciality, you get them to answer the questions, and then that's how you base the marking of it. And typically you get around 10 to 20 experts to answer the questions, so you can assign the scores, and how many depends on what you're planning to use the assessment for. So in a learning context, somewhere around 10 is generally considered acceptable. If you are trying to use it more as an evaluation of someone's clinical competence, then you tend to prefer around 20. And what's interesting about the question format, and the reason why I chose to study it as part of my master's project, is because the scenarios are designed to have the ambiguity, which as family medicine doctors we are dealing with every day. And the fact that the answer scale is graded means that each question doesn't have 1 correct and 4 incorrect answers, as you would typically get with, say, a multiple choice question. But you have a most correct answer and then a few ones that are also reasonable. And that's reflected on these scores, which I'll talk through in a minute, which lie somewhere between 0 and 1. So when I go through the scoring, I'll kind of explain that in more detail. But what you get is a more representative situation of a doctor having a possible variety of different options of decisions that they could make with the patient. Some might be more suitable, some might be slightly less suitable, but it's not this black and white, 1's correct and 4 of these answers are incorrect. So I'll just quickly show you how that scoring works. So when you score the answer, so this is each of the answers, so -2, -1, 0, +1, +2 for each question. What you do is you look at what the experts chose. And so you assign the score by the number of experts that chose this answer over the number of experts who chose the most popular, the most common answer. So I'll just kind of show you that here. So this is the question that I sent out to GPs in the UK to sort of score this assessment. And so when I sent out, I had 13 responses, and we can see here that 10 of the experts thought the most appropriate answer was +1. So atrial fibrillation is slightly more likely given this history. 3 of the experts thought that it was +2, so atrial fibrillation diagnosis is much more likely given the fact that he drinks this amount of alcohol. And then you can use this these responses from the experts to assign the scores. So if the candidate put -2, because none of the experts chose that, they would get 0 points for that question. If they chose -1 and 0, again, as you can see on the left, none of the experts chose that, so they would get 0. If the candidate chose +1, so that's the most popular answer given by the experts, they get full marks. So that's 10 over 10 if you do the sort of equation there. And that gives you a candidate would get a score of 1, so a full mark if they chose that. If the candidate chose +2, you can see it was still chosen by some of the experts. So 3 of the experts chose it. 10 of them, however, picked the most popular answer, which was +1. So you simply do 3 divided by 10, and that gets you 0.3. So if a candidate highlighted +2 as their answer, they wouldn't get 0 marks, they would get 0.3 of the marks. So there's a bit of a graded marking scale because there's not necessarily 1 complete correct answer and 4 incorrect answers. There is this graded scale. So as an assessment of learning, so by assessment of learning, what I mean is a sort of summative assessment. Generally evaluating clinical reasoning skills against a sort of set threshold to say that someone is good enough to be a family medicine doctor is really challenging and really tricky, and it's not an easy thing to do on a sort of written assessment. So the use of SCT as a summative or assessment of learning of competence is very tricky. And there's ongoing debate in the literature, which I won't go through in too much detail, but essentially there's quite a few sort of different takes on how reliable and valid SCT is as a measure of clinical reasoning to sign someone off to say, yes, you're good enough to now be a practicing GP because you passed this exam. And because of that, it does limit its use as a summative assessment, and I'm not aware of any universities or family medicine training programs that use it for that purpose, that use it as a, yes, you've passed this SCT exam, so now you can work as a GP. So it does continue to limit its summative use. The reason why is that you are using experts, and sometimes experts can be wrong. So if there's a common misconception or an under or overestimation of a particular clinical piece of information, then that might be inappropriately assigned a score, and that then piece of information might be passed on to the next next generation of trainees. There's also generally it's considered that clinical reasoning skills are supposed to sort of correlate with the level of clinical experience. Whereas when you look at SCT being used in this context, it's not consistently able to differentiate a trainee from an attending or a medical student from a resident. So it does in some contexts, but it doesn't always do that. The use of the 5-point scale, while it's interesting and the reason why I chose to study it from a learning point of view, does result in, when you look at the sort of numbers, the scores nearer the middle of the scale, so the 0, the -1 and the +1, tend to, over a whole assessment, be allocated higher scores than -2 and +2, the more extreme ends of the scale. And what that means is then if you have candidates that don't necessarily know the answer, they may strategically choose answers in the middle of the scale because that's more likely to get them points on the assessment. And then there is some issues with candidates' misinterpretation of the question just because it's not used that commonly. So the meaning of the 0 option, for example, sometimes is misinterpreted as well. We don't know, whereas actually the 0 should mean that the new piece of data does not influence how likely the hypothesis is. So it doesn't make it more likely, but it doesn't make it less likely. It just stays the same. Whereas some candidates may misinterpret the 0 as being it's irrelevant or it doesn't matter to this piece of information. So there's a little bit of a concern about misinterpretation there, although that can be managed by sort of quite clearly explaining it to candidates. So what I chose to do is study SCT more as an assessment for learning, so in a formative context. And that's just because the graded scale and the sort of graded answer scale and the fact that there's ambiguity in the scenario emphasizes to the candidates that actually there are several justifiable courses of action or decisions that could be made based on this information. And that, in theory, more closely resembles what we do on a day-to-day clinic and how we make decisions as doctors in real life. And so by exposing the candidates to this sort of complex decision-making, the uncertainty built into the scenarios, SCT, the script concordance testing, allows learners to kind of learn from this experience, to kind of see how they decided to make a decision when they weren't sure about all the facts in a safe environment. And you can do lots of different questions over lots of different family medicine topics or clinical conditions. You can do it in group settings and you can do it relatively quickly. So the advantage of sort of this compared to how, say, the RCGP in the UK references how us as trainees would learn these types of skills, the way it represents it in our curriculum is saying, well, case-based discussions with your educational supervisor or reflection on cases that you've seen in practice, which is good and it is very helpful. But obviously that's not practical across big groups, and that's not really that practical within a short time frame. So here what we can do with the SCT assessment is cover lots of different clinical topics and get groups of trainees together to kind of work through scenarios together as well. So that was the reason why I decided to study it as the topic of my dissertation, as a learning tool, to see whether I could see whether SCT could be helpful for GPs, family medicine trainees, to help develop their ability to make complex decisions, to think about how they make decisions in this situation of uncertainty and ambiguity. The title, as I didn't mention earlier, apologies, the title was about Think-aloud SCT, and that's just a slight adaptation on the original question format that came in sort of a few years after the first question format was proposed. And essentially what you do, it's known to actually help enhance the kind of learning experience of SCT in a formative context. And what we ask the candidates to do is to justify the response that they're given on the scale. So if they put -2, they just justify it with a short rationale. So -2 because of this. And so that's all the think aloud opponent adds in. But what it does is, rather than letting the candidate just circle an answer, it makes them reflect more deeply on, well, why have I chosen that answer? And what sort of factors have I sort of gone through to actually choose that answer? And what was really helpful and part of the project that I'll go on to talk about is actually these can be prompts for discussion between trainees during the feedback or during a sort of group activity, and the sort of comments and discussions might highlight certain areas of uncertainty or how they might manage the case in real life, and that was a really good springboard for further sort of discussion and learning. So before we move on to that sort of piece of work that I did, I just wanted to kind of highlight the relevance of SCT to family medicine training, and hence why I'm sort of presenting it to you today. So there's an association between the negative influence of managing uncertainty and family medicine trainees' well-being and performance during their residency. And that's come out of a sort of cross-sectional piece of research in Australia. And the particular sort of aspects that fear of managing uncertainty, or fear of uncertainty and having to make decisions in the context of uncertainty, tended to raise the clinician's anxiety, concern about bad outcomes. But interesting also, it led to a higher reluctancy for trainees to disclose uncertainty with patients when they're making decisions together. And this relationship between the sort of negative influence of managing uncertainty and these factors tended to be greatest in the early stages of training, and then get better as they gain more clinical experience. Part of the reason also why I did this project with sort of very early stage family medicine residents, so in the first year of them starting their family medicine training. And then clinically, family doctors, we need to explain rationale and uncertainty involved in the management options available to patients, because that influences the patient's decision to decide what they would like to do next. And actually being able to, as a doctor, to explain what the uncertainty is and why there's uncertainty that's there is a really important skill. And this is what learners are sort of thinking about when they're doing the Think Aloud SCT and they're picking an option. They're kind of sort of encouraged to engage in that cognitive process of working out, well, why is there uncertainty in this scenario, and how might I be able to sort of deal with that in real life? And then when they get the marks back and they have a look at sort of what the experts have done, they can then reflect on their own choice on the scale, their own sort of rationale that they've written down in their sort of alongside their answer, and that reflection then can help them develop their skills in complex decision making. So that was the kind of theory. And as I mentioned at the start, the research into sort of structured activities like this, deliberately designed to develop clinical reasoning skills in the context of ambiguity and uncertainty, which is what we deal with as family medicine doctors, at the moment is lacking. So moving on to what I did. So what I did was I looked at what UK general practice trainees learning experience of using Think-aloud script concordance testing. I have to try to leave it quite broad as possible because no one had yet done this piece of work looking at Think-aloud SCT, looking at an in-depth qualitative exploration of trainees' learning experiences. Because I'm a family medicine GP trainee, I did it within the context that I'm familiar with. So I did it with a peer cohort of general practice trainees here in Oxford. And so first thing first, I designed the educational activity. So there's one other group based in France that already had a family medicine SCT assessment, and they very kindly let me have access to that SCT paper. So I translated it into English and then sent it to trainees. They had 10 questions, so each part is in 3 parts, so 30 kind of questions overall, 30 marks overall. They were sent it in advance. They were asked to complete it as a unsupervised open book activity, and they were given a few weeks to do it before the actual education teaching afternoon that I was hosting. What they then did is they, when they finished the paper, I then sent them a copy of the mark scheme to the scoring assignment. When I did that, what I also did was ask the GPs that were the experts that I used to kind of grade the paper to also write a 1-line or few word explanation for their choice. And I added that into the mark scheme that I sent to the trainees so that they could see what the experts were thinking when they made their choices as well. So as I mentioned, so I had 13 GPs around the UK who also completed the paper very kindly to put their 13 at the average 13 years post-qualification. They were around England, Wales and Scotland, so I tried to get a sort of representation from broader areas in the UK rather than just Oxfordshire. And I used that to then score and mark the assessment and provide the sort of rationales that I then shared with the candidates. So then once the paper was done and they'd received a copy of the mark scheme, the trainees then came to an education session. It was done in COVID years, so it was all on Zoom. And in small groups, they were each allocated questions and asked to discuss that as a small group, so 3 or 4 trainees each were allocated 3 questions from the paper or for one group. But they were asked to discuss each question in depth, looking at the rationales that they'd provided, looking at the rationales that the experts had provided, and in particular, looking at why there might be a spread of different answers between experts. These are all these are all trainees who've been working as doctors for a long time, all experts that have been working as GPs for a long time. So why are they still giving different answers to the same question? So I asked the candidates, well, why is that the case? Why is there uncertainty? Why is there difference in opinion? Why are some people saying +1, some people saying +2, some people saying 0? Like, what is it in the scenario that's led to that? And how can that be relevant to what we do when we're sitting with a patient? How can we deal with either the uncertainty or whatever's led to that difference in opinion? What strategies can we have to move that forward? What data could we gather? What conversations could we have? Could we share that with the patient? How could we manage that situation? So that's what the candidates were asked to do. And then they fed that back. So then we all met together as the whole group, and each group kind of then talked through each question, the aspects that they discussed in more detail, and the sort of way that they would approach that scenario in real life. Were they being, should they have to deal with that? And then that was fed back to the whole group, question by question, and that was the end of the education activity. So just to show you what the candidates, so this is the same question I presented earlier, but this is what the candidates' questions, this is one of the 10 questions that they did for I gave them as the paper. So you see at the bottom there, rather than just circling an answer on the scale on the right there, they put the answer, but they also have a line where they need to write a justification for their answer. So that's the Think-aloud aspect of it. So that's overall what the Think-aloud SCT question format looks like. And that's what the candidates, the trainees were asked to do. The mark scheme, as I said, we So this is how the sort of scoring assignment worked, and this is what I shared with the trainees when they had completed the questions. So we kind of went through earlier how I got these numbers. But what I shared for each question, I shared with them the graph to show the spread of the different experts picking different things. And then I also shared with them the little rationales, the justifications that the experts had given. So these are the ones just from the experts. So I shared that with the candidates. In here, obviously, we only have answers for +1 and +2, but we can see there's it's just a little bit of an insight in terms of why did they pick +1 and why did they pick +2 for each of the different experts. So that's what the candidates would have seen when they get the mark scheme back. So they can look at their answer and they can be like, oh, I picked +1. But rather than just being like, okay, fine, I got the answer right, they can also see, well, oh, I can see some experts also picked +2. Why was that? And they can then think back to their rationale and their justification, link it back, and then hopefully have develop a bit more learning from that. What's quite interesting about SCTE is the fact you can have the way you design the question can lead to a real spread of the expert responses. So these are just examples from the paper that I sent out. But it's quite interesting how actually you can choose to design your questions in a way to have more or less spread from the experts. So if you have more uncertainty or a less clear-cut diagnosis or next decision that needs to be made, you can get the experts' responses will tend to be quite varied. Whereas if it's a lot more sort of very guideline-driven question that's got lots of evidence and very sort of built into practice, and the scenario has some uncertainty, but actually it's relatively clear what the steps are, you might actually get then only 1 or 2 responses being picked by the experts. And that's quite interesting in itself. And you can see some of the questions, the one on the bottom left, actually GPs picked across the whole scale. And while as a summative assessment, so for trying to justify someone's clinical competence, that's not particularly helpful as an exam format. Actually, as a learning exercise, having experts choose across the whole scale, but also provide their rationale for that, was actually some of the best prompt for further discussion amongst the trainees and actually develop more of the learning from that. Whereas that question would have been excluded from a paper where it being used just for summative purposes. So I kept those questions in deliberately to try and sort of strike up more debate and more discussion amongst the trainees. So what did I do? So I had 11 trainees in my peer cohort group in Oxford complete the paper. And then I invited them all to take part in semi-structured interviews. And I then transcribed the interviews and analysed the learning experiences that they discussed using Brown and Clark's approach to thematic analysis. And what were the findings? So I had 11 interviews. The mean duration was 41 minutes. So I had a lot of data to go through. I copied and pasted the whole of all of the interviews into a word cloud generator, and these are the sorts of most common words that tended to come up. So a few of them were quite positive. I mean, as you can see there on the left, real life, interesting, various different things, training, discussion, justification. So quite sort of interesting to kind of sort of initially have a look at what sort of topics were coming out of the interviews. So then more formally doing the thematic analysis, generated codes. I won't go through the sort of detail of that. I assume some people are familiar, but some people might not be. But anyway, we code the interviews for sort of new piece of information or interesting pieces of information, and then I categorized them, and then I kind of grouped all of these different codes into a sort of overall summary, just so I could kind of, as the sort of person exploring the data, kind of get an insight into what I'm dealing with. I'm not going to talk through this picture, but it's quite interesting when you finally look at how your mind works and how you categorize data, and just sort of created a mind map just because I thought that was the easiest way for me to kind of get my head around a lot of the data. I won't talk through all of these things. I'll go through it more broadly in a second, but this was kind of all of the total summary of all the kind of topics and points that came across from the trainees following the interviews. But what I did was then just have 3 broad themes just to summarize all of the interviews in a more concise way. So theme 1 was developing complex decision-making skills. Theme 2 was an opportunity for self-evaluation and awareness. And theme 3, which one wasn't necessarily expecting to come out of it, was actually promoting community and a sense of professional identity. And I'll just work through the themes quickly, just to kind of summarize the sort of data that came out of the interviews. So theme 1, developing complex decision-making skills. And this is probably where my sort of interest in the area kind of originated. So what was found was that exposure to decision-making in the context of uncertainty was valued as more closely representing real-life clinical practice. So some quotes here: it stimulates you to think, how do I actually manage that situation or that consultation with the patient, knowing that I'm not certain? The Think-aloud format in particular prompted trainees to engage with, acknowledge, and deliberately reflect on their clinical reasoning. So you're actually having to use the skills that you use in a consultation, where you're sifting through the information, trying to work out what you think about it. And where there's information missing, you're trying to fill in those gaps. And the ability to compare their decision-making and rationale to those of the GP expert panel was found to enhance the learning opportunities for the trainees. I think the whole point is the explanation or the rationale behind the GP's actions. That's how you learn from what their thought processes are. So theme 2, the opportunity for self-evaluation and awareness. So trainees evaluated their own performance, identifying and acting to address their own learning needs. You're exposed to gaps in your knowledge and reminded of certain pathologies. We discussed them in the teaching session and I looked them up beforehand. The alignment of their clinical reasoning with the GP panel, as well as the peers during the educational activity, was found to be quite reassuring to trainees about their own professional development. It's a reassuring process when you thought the same as the GP panel. And when you didn't, it gives you a greater understanding of why they would make those decisions. And trainees perceived the challenges of managing uncertainty raised by the questions and reflected on the value of acknowledging and contemplating their own emotional response to managing uncertainty and the difficulty of that. It's not very satisfying as a question because you think, well, what is the actual answer? Why does nobody agree? Ambiguity is a part of real-life clinical practice and we need to learn to deal with it. It's reassuring that it's okay to have that feeling of uncertainty. And then theme 3, promoting community and professional identity. So the Think-aloud approach allowed trainees' thought processes to be appreciated and validated in relation to the experience and expertise of others. So it's really interesting to sit down and talk through it with other people at the same level as you, bouncing ideas off each other, getting a feel for what they thought, their justifications and their thought processes. You're gaining experience through other people's experience, learning from other people's clinical hours. Complex decision-making was recognized by trainees as an integral part of the identity of being a GP. Engaging with an educational activity designed to develop this skill contributed to a sense of legitimate progression through their training. So I think introducing uncertainty into the mix is a step to independent practice. At some point, you start to tentatively develop your own expertise. Maybe we're not there yet, but at least you can have faint glimmers of it coming. So overall, the educational value of Think-aloud SCT was generally considered to be acceptable, engaging, interesting, and a versatile assessment designed as a learning tool. By adding in the Think-aloud approach, trainees were encouraged to move towards higher order evaluation, so kind of reflecting on their own decision-making practices. And the learning that can be derived for these questions through sort of guided reflection on their performance in the peer groups, but also looking at the experts' experience, which sort of gives them an experience, and then the feedback from that they can then use as a sort of for their own development and their own learning in the sort of model of experiential learning that Kolb described, without necessarily having to have had those consultations in real life. They can still gain from that learning process. And then scenarios prompted trainees to acknowledge their feelings around managing uncertainty and complex decision making in primary care, and actually begin to think about how they might deal with that and how they're going to approach that as they progress through their training and as they qualify as family doctors. And then the last part is, well, what about the pass mark? So there's a little bit about standard setting, and this kind of came up in the interviews with the trainees, and so I did a little bit more work on it, particularly interested in how SCT is marked and how you decide what a pass mark is. And also what was quite interesting is that the trainees found that that was still relevant, even though it was used as a learning activity rather than as a specific test to see whether they were able to qualify in practice. So the role of standard setting, as I mentioned previously, having a set threshold to say, yes, you are good enough to qualify, or yes, you are good enough to move on to the next year of your training is very, very hard. But despite this, the trainees found that having pass marks for each question was actually helpful from a learning point of view. So I think having a pass mark for each question makes it easier to engage with the answer. You can break it down and see why you did well. And for anything you didn't score well on, it gives you an opportunity to find out why that was the case. So it was quite interesting to hear that actually having that pass mark or a mark scheme with that sort of aspect to it, that numerical aspect to it, was also valued by the participants. I'll very quickly summarize how SCT is marked and how you get a threshold, standard set in the paper. So what you actually do is you basically you mark each expert that you ask to answer the questions. So although you assign the scores by looking at what the sort of spread of experts for each question, if you take each individual expert and just look at the answers they chose, they will have a mark for the assessment. And then you can do that for all the different experts. So if I'll get 13 different marks from the 13 different GPs, you can find the mean for that, and then you can base the pass mark on that. In the literature, generally, what people say is you either subtract 2 to 4 standard deviations below the mean, and that's your pass mark. So if you're dealing with medical students, they usually say we'll take 4 standard deviations lower than the mean expert mark, and that's your pass mark. If you're a resident, then it should be -2 standard deviations. The issue I had with that approach was, well, who decides 2 and 4? It seems like a relatively arbitrary number to pick. Okay, well, as a medical student, you should be -4 deviations, that's the pass mark. But now you're a family doctor, family medicine trainee, it should be -2. Who's making that decision and why? So more recently, there was another group that sort of used a new approach, and they adapted the approach that's commonly used for multiple choice questions, so the Nadelsky approach, and they adapted that for SCT. So what they did here in this approach is defined by modeling the behavior of a borderline candidate. So you're trying to work out, well, this is the minimum I expect from a candidate. What would their behavior be in this situation? And if you model that with the question, you can then derive a pass mark from that. So what you would expect a candidate to do is rule out the clearly incorrect responses and then not be entirely sure which one of the sensible options is the best one. So then you randomly select between them. So that's the kind of modeling behavior of how you would do it with an MCQ question. So if there's one right answer, you'd be like, well, 2 of the answers in these 5 are clearly wrong. So we'd expect a candidate to get those, to exclude those. But then these 3 answers are all slightly, there's not quite clear which one's the best. So we'll let them randomly pick between 3. And then if you model that, you can then get a pass mark based on averaging the scores out. So in this paper, in this group, they modeled that behavior based on discussion between 3 quote unquote clinical academics. I don't really describe what that is, but they would say that we're not part of the expert panel. So they got 3 sort of experts or other experts to go through the whole paper, decide what the minimum or the borderline behavior would be expected is, and then use that to derive the pass mark. The difficulty with that is it's quite resource intensive, and for me personally, it wouldn't have been possible. I wouldn't have been able to get 3 GPs to sit in a room with me for a few hours to go through each paper, every single question. And also then how many experts do you have who picks who they are? So there's a few sort of issues with it. And for me personally, it was just the fact that it was completely impractical for me to be able to do. So what I did was slightly update and modify that approach to make it more practical and feasible, just so that it could still be done in this learning context, and it would allow more flexibility of using standard setting for educational purposes. So yeah, why did I do it? To encourage the use of standard setting in formative settings for learning, and therefore add the educational value to SCT by reducing the time and resources required. So how did I do it? So rather than modeling the borderline candidate behavior from 3 people sitting down in a room together and working it out, I'd already collected 13 groups of responses from experts around the country, which I used directly to model the behavior. So I didn't have to get another 3 people to sit down together and do it. I'd already actually collected 13 answers. So I used those answers that I'd already collected to now standard set the paper. So what would a borderline candidate be expected to do? I would expect them to exclude all the options that none of the expert panel chose, and then to select randomly between the remaining options. So I'll just show you how that works. So going back to that same question again. So what we'd expect here is the minimally sort of borderline candidate should be able to work out that -2, -1, and 0 are not appropriate responses. And that's reflected by the fact that none of the experts chose that. So that's point 1 here. So exclude the options not chosen by any of the expert panel. So -2, -1, and 0. However, a borderline candidate probably wouldn't be able to work out whether +1 or +2 is a better answer. So they would then just randomly select between those 2 responses. So they'd either select +1 or +2. If you then calculate the scores of what they would get in a paper, you basically then just add up and divide by the number of choices. So you add up 0.3 and 1 divided by 2, and you get 0.65. So the borderline candidate in this question would be expected to get 0.65 marks from this question. Obviously, it doesn't make sense for just one part, but if you add it up through the whole paper, you'll then get a pass mark. And so what you can do then is get an overall pass mark for each individual question by adding A, B, and C together. And you can get an overall pass mark for the paper by adding up all 10 questions. So this overall finally is what the candidates actually saw when they got the questions back. So for question 1, the table of results, they could see what they would have scored. And then the graph showing the spread and the justifications, which I've shown previously. But I also then put the pass mark on the side, and that was modeled by this modeling that I discussed. So they can see a candidate would go through and say, well, say if I picked +1 for question A, okay, I got 1 mark there. I chose 0 for 2, so I got 0.86. And then I chose 0 for 3 as well, so I got 2.86 marks in this question. So I passed the question. I'm comfortably over that 2.2 mark. So that's how I kind of presented it to the candidates. And just quickly, the pros and cons of that approach. So the pros are it's still grounded in the standard set and the pass mark is still grounded in what experts think and their interpretations. It provides a pass mark for each question, and that reflects the difficulty of the questions. If there's more spread between the experts, the pass mark is lower for that question because it's more challenging. It's quick and low resources, so it's just me doing the maths. It works for individual questions, allowing ad hoc use of SCT questions. So one of the trainees in the interviews said, well, actually, you could put 1 or 2 questions at the end of a teaching session and use that as a prompt for discussing more complex cases to do with that scenario. So we recently had some urology teachers, and they were talking about managing benign prostate disease. So they were saying, well, why don't you have a question about that on the end of a teaching session, and then where they're spreading the answers, we can talk about, well, how do we manage this particular scenario? And if you, with this approach to standard setting, you can still get a pass mark, and you can still kind of use individual questions as and when you want to use them. And candidates found, when I sort of explained this approach, the trainees felt that they thought it was a very reasonable approach, and it seemed a valid way of making a threshold for passing the paper. The downsides are there's no normalization step. What that means basically is that each question is weighted slightly differently if you add them up for the whole paper. So some questions are weighted slightly more and some questions are weighted slightly less. Now, the way that works out was that the ones that are more ambiguous, the one where the experts spread more, tend to have less weighting in the overall pass mark. I don't think that's necessarily a bad thing, but generally it's tend to be considered that you should have each question contributing the same amount to the overall pass mark. Whereas this method, the harder questions contribute a little bit less to the pass mark. And the other downside is that, as I mentioned about this this sort of modeling the behavior of a borderline candidate, once they've excluded the options that are clearly incorrect, in theory, the modeling is that they randomly choose between the remaining options. Now, because of the use of a scale, and as I mentioned earlier in the talk, the scales, the answers around the middle of the scale, the -1, 0, the +1, candidates might deliberately, strategically decide to pick those options because it could elevate their score. So this modeling of the pass mark assumes that they pick randomly between remaining options, but actually that might not be the case. They might tend to have a preference for picking the less extreme options, the 0s, the 1s, the -1s, particularly if they're not sure about the answer. So overall, and brief take-home messages, the Think-aloud SCT format is a relatively new assessment. And while it has its challenges in terms of summative assessment for sort of competency, it's increasingly being recognised and used in clinical education across different specialities because of its learning, because of its educational value. This study with GP trainees was the first sort of in-depth qualitative exploration of postgraduate trainees' learning experiences with Think-aloud SCT. And in conclusion, I think it supports its further use as a sort of distinctive, interesting and structured learning activity to help GP trainees develop complex decision-making skills that they're going to need throughout their careers. And that standard setting, having the pass mark, still seemed to have educational value for the trainees. And I've just presented a sort of quick approach, an update to the approach that's designed to be a bit more practical and feasible for people to deliver without necessarily requiring lots more resources. Perfect. So that's the end of my talk. Apologies, I haven't got a clock on here, so I'm not sure how far time I've got. But hopefully that was interesting, and hopefully people have some questions or comments or just general discussion about what they think about this this assessment format.
Yes, thank you very much, Raj, for your presentation. It was a great presentation. So I think, Charo, if you agree, we have 5 minutes left.
Yeah, go ahead. And then if there are people who would like to stay, because me too, I have found this presentation fascinating. So yes, go ahead.
So I didn't realize I didn't have the clock up. I didn't realize I left so short time for questions.
Don't worry. You talk a lot, but everything was very, very well received. So anyway, Samira, go ahead, please.
Yes, thank you. So do we have any questions for Raj?
I could throw one or two out for sure.
Yeah.
Should I go ahead? Yeah.
Yes, sure.
Okay. I just one of them is background, and then one of them is more just to get your opinion on something, Raj. Do you mind explaining why do we call the script concordance testing? I'm not sure I understood. Like, where's the script and where does the concordance come in?
Yes, sorry, I didn't explain that. So the script comes from something called illness scripts, which is the sort of internal processing that the doctor has when they come across a new scenario. They have these sort of scripts of what the illness should look like or what sort of patterns things should look like, and that's the kind of internal clinical reasoning that they go through. And that follows that model of, okay, it could be this, or I've got this new piece of information, oh, okay, that's probably less likely, so it might be more likely to be something else. And those have been called in the literature illness scripts, so that pattern doesn't quite follow this disease as I would expect it. So maybe this disease is actually not the diagnosis, maybe it's something else. So that's the kind of called illness scripts, and the script concordance was trying to align the question format to that internal processing. That's where the name comes from.
Okay, thanks. It just strikes me that, you know, we all know about the prominent role of uncertainty in clinical decision making in primary care. Yet when we you mentioned that you actually weight questions lower if they address topics where there's a wide spread of expert opinions on what it should be the correct answer. So that strikes me as kind of discordant with the idea that we should be, testing trainees' abilities to deal with uncertainty in the first place.
And I think that's one of the reasons why I think actually as the learning tool here, the group discussion and the actual thinking and the reasoning through why there's the spread was where the value was, rather than the number. Because yeah, as you say, yeah, if those are weighted less, then the candidate who gets the easier answers correct, but struggles with the more ambiguous and challenging questions probably would still pass. But yeah, I think there is I personally don't think it potentially is like, because of these challenges, going to be used as a sort of end of training or sort of summative context. So I think that all comes from the value of sitting down and talking through it and people having that debate and that discussion. But that makes it very hard to use that. How can you kind of actually evaluate that at the end of training to say whether someone's good enough or not? It's very, very difficult, but I kind of took it as well. You can still use it for the learning.
Yeah, thank you.
Thank you. So we have Marianne and then Charo.
Sorry, on my phone, it's hard for me to figure out how to unmute. I wanted to thank you, Professor Patel, for this very interesting talk. I have so many different thoughts going on in my head right now. I think it's I don't really have a question for you, but I just wanted to thank you. There are so many interesting points that I think really could be integrated into our residency training. The whole, as Roland mentioned, just the explicit teaching of managing uncertainty, the group discussions, which I think generally promote professional identity formation, promote feeling of safety, feeling of ability to have divergent opinions and to really be patient-centered. I think there's so many pearls to take away from this presentation that I just really think it's fascinating. And yeah, I don't have a specific question, but basically, how fast can we roll it out, I guess I would say.
That's very, very kind of you. Actually, one of the things I sent out to the trainees when I sent the paper out, there's a short piece for 12 strategies for managing uncertainty. I'm not sure if it's specifically primary care or not, but actually that I sent out alongside it, because when you talk as a GP to meet people, people often in other specialties say, I can't be a GP, I just can't deal with the uncertainty. And as the peer cohort, this was in my first year, so ST1 we call it in the UK, it was quite a prominent thing that was coming up week after week in our teaching sessions. And so I was planning on doing this anyway, but it fitted in quite nicely with the fact that actually it was clearly very prominent in my peer cohort's minds at the start of training. So I would assume that's relatively prominent in trainees across other settings as well. And so actually, yeah, just having a sort of session deliberately on how do we do it, how do we manage it, and then having this sort of practical thing that they could actually get their teeth into, as well as just having an open discussion, kind of just focused it a little bit rather than just saying, right, how do we manage uncertainty? It's actually, well, here we go, here's some scenarios, here's some examples, here's some spread of different people's opinions, and then use that as a springboard, which seemed to just ground the discussion and help it kind of help the conversations flow, rather than just sort of being a bit too nebulous a task to work out how we manage uncertainty.
Yeah, Charo?
Yes, so me too. I wanted to congratulate. I have loved any piece of the presentation. I found it fascinating, but there are two things that I would like to highlight. First, your rationale for transforming an initially summative measure into a formative one. I found it absolutely fascinating. This is one thing. The other thing is what you have highlighted that, and also Marion has just mentioned it, that the fact that residents in family medicine in general practice consider that clinical reasoning and mastering these processes is the backbone of their identity as professionals, I found it absolutely fascinating and very reassuring. So bravo. Do you know if it has been a replication of this study you conducted in the UK in other contexts, because I think it will be extremely interesting to see what is going on with other residents in family medicine outside UK, because as you know, in qualitative research, context matter. So matters. So do you know? By the way,
I don't know. I haven't seen it, but I haven't.
You have not looked for it
as much. I haven't looked in the last sort of recent past, but yeah, from the interviews, that was certainly something I wasn't expecting to come up. That was quite interesting from my point of view as the person interviewing them, to kind of see that discussions were being led that way, which was which was interesting. Maybe because I did it as the peer trainee as well, I probably hadn't necessarily in my own head thought about all of these things as well.
But that makes sense. So they are professional identity is something that is co-constructed through discourse in interaction with the others. So the opportunity to think aloud with peers, but at the same time having the reference of the experts in the field, I found it extremely. Professional identity is one of my topics of interest in my own lab, so I found it absolutely fascinating. So, and I would invite my colleagues at the FMER who are clinician teachers to think about maybe it would be interesting to replicate a study in our context. Just is an idea. By the way, Dr. Patel, the article that you have referred to, 2012, with Stuart Lubatsky and Valerie Dory at the beginning, they are members, or they were members of the Center for Medical Education. Valerie is not there, but Stuart is a neurologist, and he's an expert in clinical reasoning at the Institute of Health Science Education.
Yeah, I actually emailed him to let him know I was going to be around.
Exactly.
But yeah, I references a couple of his papers in my dissertation.
Yeah. Anyways, thank you so much.
No, not at all. It's very kind of you. Thank you.
Right, thank you. Do we have any other questions, any other comments? If not, we can conclude the webinar as we are 5 minutes over the time.
Sorry, apologies for that.
No, it was very interesting because we had more questions and more comments. So it shows that people are interested in the topic and your presentation. Thank you.
No, it's very kind. Thank you so much for inviting me along. I appreciate it.
You do a very nice way to closing our FMER webinars for this academic year. Thank you so much.
That's very kind. Well, thank you everyone for listening and staying around.
Bye-bye, and good trip in Montreal.
Thank you.